Good evening, everyone. I'm Asfa Fazilat from Nizam Institute of Pharmacy, a family fourth year student and a Medodrix volunteer. I'm pleased to introduce Medodrix as an ISO certified organization committed to supporting the family community. Medodrix offers specialized clinical modules and lectures in areas such as clinical pharmacy, oncology, infectious diseases, and more, helping pharmacy professionals grow in their careers. We provide timely health information with the latest updates in medical field, serving both the public and healthcare community. Medodrix is dedicated to empowering family professionals with the knowledge and tools they need to succeed. It is my pleasure to introduce our speaker, Dr. Sufia Iram Irshad, a highly skilled clinical pharmacist with a commendable background in critical care. Since 2021, Dr. Sufia has been working at Continental Hospitals in Hyderabad, where she has gained expertise in areas such as emergency drug dilutions, developing protocols, dose adjustments for various types of dialysis, and antimicrobial stewardship. Dr. Sufia is a graduate of Deccan School of Pharmacy in Hyderabad, where she led the foundation for her deep understanding of pharmaceutical sciences and clinical practice. Her focus on critical care demonstrates her dedication to ensuring optimal patient outcomes, even in the most challenging medical situations. Please join me in welcoming Dr. Sufia, who will be sharing her insights on mastering insulin therapy, types, dosing, and management in diabetes care.
Hello, hi, and very good evening to one and all. Thank you so much, Asfa, for the introduction. And I would just like to take a moment to thank Medodrix for having me to talk on this wonderful topic this evening. So, yeah, let's begin. I'll just share my screen. Yeah, Asfa, can you just guide me and tell me if my screen is visible to everybody?
Yes, ma'am, you're visible.
Okay. Yeah, so thank you so much, Medodrix, for this opportunity for having me this evening to talk on this wonderful topic. Without any delays, let's just begin. I first of all, I just hope I don't get you all bored with it. I'll try to keep the topic short, and because it is insulin, so sweet and as simpler as possible, which can be understandable. Yeah. Is my screen visible?
Yes, ma'am, you're visible.
Okay, one second. Okay. So the topic for today's session is mastering insulin therapy, the types, dosing, and management in diabetes care. This is Dr. Sufia Iram this side, a clinical pharmacist working at Continental Hospitals in Hyderabad. So let's begin with this topic. But so first, before we start with the session, let us discuss a little about why this topic. Why have we selected this topic at this time? Well, insulin, we all know that diabetes and insulin is a very vast topic and it can be taken up at any time of the year. But particularly this time of the year, why? Because of the World Diabetes Day. The World Diabetes Day has been established in 1991 by the International Diabetes Federation with the support and economic with the support from the WHO in response to the growing concerns about the health and economic threat posed by diabetes. World Diabetes Day became the official day in 2006, and since then it is marked every year on the 14th of November, which is the birthday of Sir Frederick Banting, who had co-discovered insulin along with Charles Best in 1922. So this was a little brief about the World Diabetes Day. Now moving on to our topic, but before directly jumping on to insulin, let's just go through briefly about what is diabetes, because we all are aware that insulin is used in the treatment of diabetes. So let's go a little through what is diabetes. Normally, in layman language, when we say that diabetes is high sugar or increase in the blood sugar levels. But if you have to give it a definition, it is a chronic metabolic disease which is characterized by elevated levels of blood glucose or the blood sugar, which leads over time to serious damage to the heart, blood vessels, eyes, kidneys, and nerves. We all are aware that it is a very chronic disease, and in the future, if it is not under control, it can cause damage to other organs of the body as well. So the different types of diabetes would be type 1 diabetes, which is also called as IDDM, that is insulin dependent diabetes mellitus, where insulin is the only treatment option for patients with type 1 diabetes. In the type 1 diabetes, your body makes little or no insulin, and it is usually diagnosed in children and young adults, and they have to take insulin every day, as that is the mainstay therapy in type 1 diabetes. Next, type 2 diabetes, which is NIDDM, that is non-insulin dependent diabetes mellitus. The cells in the body don't use the insulin properly, and we all know that it is the most common type of diabetes. The risk factors that could lead to type 2 diabetes would be overweight or obesity or a family history of diabetes as well. Next, coming to gestational diabetes, it is the diabetes that develops during the pregnancy and it often goes away after the baby is born. However, there are still chances of developing type 2 diabetes later in life for females who had gestational diabetes during their pregnancy. So this was just a brief about the types of diabetes. Moving on to the symptoms. The symptoms for both type 1 and type 2 diabetes are quite similar. That is extreme hunger or thirst, peeing more often, which includes bedwetting in children, extreme tiredness, and blurred vision. These are some of the common symptoms which we can see in both type 1 and type 2 diabetic patients. Whereas crankiness or behavior changes, vaginal yeast infection in prepubescent girls, or diaper rash in babies is something which we can see in patients with type 1 diabetes. Whereas skin darkening, especially around the neck, groin, and armpits, and repeated infections are some of the symptoms that we happen to see in patients with type 2 diabetes. Next is the treatment of diabetes. Will not go much into the non-pharmacological. Well, there are two types, non-pharmacological and the pharmacological treatment. The non-pharmacological includes healthy eating and physical activity, whereas the pharmacological includes the insulin, on which we are going to talk in the further slides, and oral hypoglycemic agents. So I'd like to take one moment over here to say that people usually say that once we start with the pharmacological treatment with like insulin or any hypoglycemic agents, then we do not need to go for healthy eating or physical activity. They usually tend to think that because we are on medications, we do not need to go ahead with this. We can eat whatever we want, we can do whatever we want, we can have a sedentary lifestyle, we can live however we want. But that is not the case. Even when we have, first of all, people with type 2 diabetes, they have to prevent themselves by, or rather each individual should be prevented from type 2 diabetes by healthy eating and physical activity. However, if the patients have already started with their insulin or hypoglycemic agents, even then they need to be having a healthy lifestyle by having healthy eating habits and by doing some physical activity. Only then there is a chance of their sugar levels to come under control. So this was just one point I wanted to convey. Now moving forward to our main topic, that is insulin. So let us see what is insulin first. So insulin is a hormone that is made by the pancreas in the body that helps the glucose get into the cells to be used as a source of energy. Now, if you have diabetes, the body does not make enough insulin or at times any insulin, or doesn't use the insulin properly, which comes through the food. So glucose then stays in the blood and doesn't reach the cells, which in turn leads to hyperglycemia, that is elevated sugar levels in the blood. Injections of insulin can help manage both. So insulin acts as a replacement or as a supplement to the body's natural insulin. Injections of insulin can help to manage both the types of diabetes. As you have seen that the insulin moves the glucose from the blood into the cells all over the body. So glucose, from where does the glucose come into the body? Glucose comes either in the form of both the food and the drinks that we consume, plus the body's natural release of the stored glucose, which is also called as glycogen as well. And glucose is considered to be the body's main and preferred source of energy. Now, all the cells of the body needs energy to function. So we can think of insulin as the doors of the cells to the in the body. Once the insulin, that is the doors open, the glucose leaves the bloodstream and moves into the cells where they can be used as a source of energy, and hence the blood glucose levels will be normal as they have left the bloodstream and entered into the cells where they can be used. But if the insulin does not function properly, if the insulins cannot open the doors of the cells, or without enough insulin, the glucose cannot get into the cells properly, and hence they turn up, building up in the blood, which leads to high blood sugar and in turn diabetes. So people most often deliver the insulin into the subcutaneous tissue, which is also called as the fatty tissue located near the surface of the skin. So the different sites of insulin administration would be the hands, that is the arms, the thighs, and the abdomen and the buttocks as well, where we have most of the subcutaneous tissue, that is the fatty tissue. However, we always prefer that if patients are taking insulin in the hospital, then the nurse, the practitioners only give it at the hands, because they will be mastered at it. Because if the patient takes it by their own self, then there is a higher chance that the insulin can go into the muscles if we take on the arms or thighs, because it has comparatively less fatty tissue than the abdomen. So we always advise the patients who are taking the insulin by themselves to administer it on their abdomen, because more of fatty tissue is over there, and there is less chance of the insulin going into the muscles, that is intramuscular. Because if the insulin goes into the muscle, it does not affect there. It affects only when it goes through the subcutaneous tissue, or in later stages through the IV. Now, moving on to the types of insulin, there are several types of insulins which are available. Each type starts to work at a different speed, known as the onset, and its effects last at a different length of time, which is known as the duration. And most of the insulins reach a peak, which is when they have the strongest effect. After the peak, the effects of the insulin wean off over the next few hours or so. So let's go and see the different types of insulin. How does it start to work? That is the onset of action, the peak time, and the duration of action, and the method of when it should be administered or how it should be administered. So first one would be rapid acting. The onset of action would be 15 minutes, as the name says. When does it peak? It peaks in 1 hour, and the duration of action is 2 to 4 hours. It is usually taken right before the meals, often used with longer acting insulins. Next would be the regular or short acting insulin, which where the onset of action would be 30 minutes. It peaks in 2 to 3 hours. Peaks as in it has the maximum effect in 2 to 3 hours. The duration of action would be 3 to 6 hours, and it is usually taken 30 to 60 minutes before a meal, because the onset of action is 30 minutes. Next is intermediate acting. The onset of action is 2 to 4 hours. That means it starts to have its action in 2 to 4 hours. It reaches the peak in 4 to 12 hours, and the duration lasts for 12 to 18 hours. It covers the insulin needs for half a day or overnight, often used with rapid or short acting insulin. The long acting, it starts to act in 2 hours, and it does not usually peak because it maintains a steady state concentration in the body, and the duration of action lasts up to 24 hours. It covers the insulin needs for about a full day, often used when needed with a rapid or short acting insulin. And then the ultra long acting, it starts to act in 6 hours, and this also does not peak as it also maintains the steady state concentrations in the body. And how long does it last? It lasts for 36 hours or even longer, and it provides a steady insulin for longer periods. So these are the different types of insulins with their onset, the peak time, and the duration of action. Now, so this is a simple graphical representation of the way the insulin acts in the body. As we can see, the rapid acting insulin, they reach the peak in a shorter time, and then the effect starts weaning off also in a lesser time, whereas the short acting starts to peak in a slightly later time, and the effect lasts a little longer and then weans off. Then next is the intermediate acting. It starts in 1 to 3 hours, and it peaks in 4 to 12 hours, and it works for a longer time, and then it starts weaning off its effect. The long acting, it does not peak. It starts towards a later time. It does not peak. It maintains a steady state concentration, and it weans off in 24 hours. So this is just a simple graphical representation of it. Next, we'll just give a glance on the classification. I'm sure many of you who are students over here might be learning about these classifications, especially the ones who are in their second years of their PharmD and more. So the classification, as we have just discussed, there are 5 different types: rapid acting, short acting, intermediate acting, long acting, and ultra long acting. So the rapid acting insulins are with three: insulin aspart, insulin glulisine, and insulin vispro. The short acting is a regular insulin. The intermediate acting insulin, which is a rarely used insulin, is neutral protamine hagedorn, NPH, also called as NPH. And the long-acting insulins are two, which is insulin detamir and insulin glargine. And the ultra-long-acting would be insulin degludec. So these are some examples of the different types of insulins. Now, let's move on to some interesting part of how is the insulin dose calculated. We as clinical pharmacists can play a major role in the hospital settings, where basically the decision of what insulin to be given and basically how much insulin to be given, how much insulin dose to be started, is decided by the treating physician based on different parameters of the individual's need. But we can still play a role in calculating the dose of the insulin. So the calculating how much insulin is required to take is usually based on two considerations. The first one is the basal insulin dose, and the other is the bolus insulin dose. A basal insulin dose is an amount that you give yourself daily regardless of the foods that you eat. And a bolus insulin dose helps correct or anticipate the carbohydrates intake throughout the day. So you'll usually correct this with the bolus dose of rapid acting insulin. If I have to explain basal and bolus insulins in a simple term, then I would explain it as basal insulin is the one which we usually give in the night time, which is the long acting insulin, and it covers throughout the day, and it is regardless of the food that we eat. It is for diabetic patients. Regardless of the food, the dose is calculated based on the weight, and it is prescribed to the patients. Whereas the bolus insulin dose, it is based on the carbohydrate intake or the blood glucose levels, and based on the weight, the dose is decided and then distributed in 3 times throughout the day, 3 times before the meals. So for this bolus dose, because we want a little quick action, so we either use short acting or rapid acting insulin. Whereas for basal insulin, we use the long acting insulins. So let's hear a little about the basal insulin. Basal insulin helps to control the glucose levels. The insulin reaches the bloodstream several hours after it is injected. It keeps the blood glucose levels constant throughout the day and in the night, and in general the basal insulin remains in the system for up to 24 hours. That is why it is called as a basal insulin or a background insulin as well. Although some have a shorter or longer cycles in the body. So all the types of basal insulins are long acting only, and depending on the type of insulin used plus the patient needs, a person should inject long acting insulin either once or twice daily. And then long acting insulin tends to have no peak activity. As I've mentioned, they maintain a steady state concentration in the body, and it mimics the natural function of the pancreas as well. It allows for constant delivery, which keeps the blood sugar levels steady throughout the day and in the night. Some advantages of the basal insulin would be easier blood sugar level management, more flexible lifestyle, less frequent injections, as we have just mentioned, lower risk of complications, and it can be used as a part of basal bolus regimen as well. Disadvantages: hypoglycemia, nighttime hypoglycemia, and weight gain. One thing about basal insulin is that it is not given individually in a patient with type 2 diabetes, but can be given in patients with type 1 diabetes. Basal insulin is usually given along with the bolus insulin in patients with type 2 diabetes. So bolus insulin, a bolus dose is insulin that is specifically taken at the times of meals to keep the blood glucose levels under the control after a meal. Bolus insulin needs to act quickly, and so that for that reason, as I've mentioned, we use the short acting or the rapid acting insulin. Bolus insulin is often taken before the meals, but some people may be advised to take their insulin during the meals or just after a meal if hypoglycemia needs to be prevented. There are two ways to add the bolus insulin. One is the fixed regimen, where the patient will take the same amount of bolus insulin regardless of the pre-meal blood glucose readings and the carbohydrate content of the food. And other one is the flexible regimen, which allows various bolus doses based on the pre-meal sugar levels, carbohydrate intake, and the activities. Now let's see how do we calculate the bolus doses for carbohydrates, that is the meal bolus. So there are two ways to calculate the bolus doses. One is based on the carbohydrates and the other carbohydrate intake in the body, and the other one is based on the blood glucose levels. So if we have to calculate the bolus dose based on the carbohydrate intake, then we need to use the insulin to carbohydrate ratio to calculate the insulin. Okay, ma'am, please go slow. Okay, I'm really sorry. I'll be a little slower. So if we have to calculate a bolus dose for carbohydrates, that means this bolus dosing is based on the carbohydrate intake, the amount of carbohydrate that we take into the body, that we consume in each meal. This dose is based on that amount. So if for this, we need to use the insulin to carbohydrate ratio to calculate the insulin dose. Now, insulin to carbohydrate ratio is the amount of rapid acting insulin. Suppose we are using a rapid acting insulin for a patient. So this ratio would be the amount of rapid acting insulin you need for a specific amount of carbohydrate in the food. That is, this is the number of grams of carbohydrate, that in simple terms, how much of carbohydrates will be covered by 1 unit of insulin. For example, we are taking rapid acting insulin. Then 1 unit of the rapid acting insulin will cover 10 grams of carbohydrates. Now, this is always subject to change with the types of insulin. If we take a short acting, then that will cover some different amount of carbohydrates. But to explain it in a very simpler form, I'm using an example of rapid acting. Again, when to give a rapid acting and when to give a short acting is always decided by the prescribing or the treating consultant. So suppose we are starting a patient with a rapid acting insulin. So we need to see how much does 1 unit of rapid acting insulin. So it covers 10 grams of carbohydrates. So let's take an example where a meal has 60 grams of carbohydrates. Now your carbohydrate ratio here with rapid acting insulin is 1:10. So 60 grams of carbohydrates should be divided by 10, that equals to 6. So basically 6 units of rapid acting insulin has to be given as the dose prior to the meal that we are taking 3 times in a day. So 6 units before breakfast, 6 units before lunch, and then 6 units before dinner. This is the dose based on carbohydrates, based on the amount of carbohydrate intake or consumption that we do per meal. But because this is practically not possible in our daily life. With like, it is very difficult, obviously it is very difficult to calculate the carbs that we are having in our food. So the other way to calculate is based on the blood glucose levels. This is a simpler way. So the range, this is based on the blood glucose levels, and it is the calculation is done based on the weight. So it is a weight based dosing. So the range in which it is calculated is 0.3 to 1.5 units per kg per day. This is a range, again, among the range based on the different parameters of the individual's needs. The prescribing consultant which will decide. Most common one, or the most common, the starting unit that we take is usually 0.55. So I've taken that as an example over here. 0.55 into the total weight in kilograms will give you the total daily insulin requirement in units of insulin. Okay, so for example, assume that the weight of the patient is 70 kgs. Then in this example, the total daily insulin dose that the patient should be taking in the day should be 0.55 into 70 kgs. That equals 38.5 units of insulin per day. So 38.5 is the dose of the insulin that the patient should be taking in the entire day. It is not per meal, but it is throughout the day. And now if we are giving it 3 times in a day, like prior to the meals, then 38.5 should be divided into 3, which equals approximately 13 units TID, 3 times in a day before the meals. I hope I'm being clear here, because for students it might be a little confusing. So I hope I'm being clear. Next, now if we have to calculate a bolus dose for high blood glucose, that is, if if the blood glucose levels are higher than the target glucose levels, then we also need to add a correction factor to it. That means an extra dose of the insulin should be going to the patient along with the daily dose. So generally, to correct a high blood sugar, 1 unit of insulin, and I mean any insulin, any 1 unit of insulin is needed to drop the blood glucose levels by 50 mg per deciliter. So 1 unit of any insulin drops the blood glucose levels by 50 mg per deciliter. So we need to use the high blood glucose correction factor to give the correction bolus. Correction factor is how much 1 unit of rapid acting insulin will reduce the blood glucose number, and the target number is the blood glucose number that you want. So let's take an example. I hope with this example it gets a little clear. For example, the blood glucose levels of the patient is 220, whereas the target blood glucose should be 120 only, and the correction factor is always 50, like 50 mg per deciliter will be reduced by 1 unit of insulin. So now, first of all, we'll see how much of amount of insulin do we need to correct here. How much of amount of glucose level do we have to correct over here? So here our blood glucose is 220 minus our target is 120. So 100 mg per deciliter is the amount that needs to be corrected. Now, how much units do we have to give to correct that? 100 is the amount that has to be corrected divided by the correction factor 50. That equals to 2. So 2 is the correction bolus over here. Basically, so 2 units of the rapid acting insulin has to be given to bring back the blood glucose into the target range. So they do not get confused over here. This 2 units is not just 2 units to be given. It has to be given along with the main dose as well. For example, if we see here, 38.5 units of insulin per day, it is the total one. If I divide this into 3, it becomes approximately 13 units. 13 units. Now, if the same patient has to be taking this correction factor, so 13 plus 2 units has to be given each time before the meal. That is 15 units should be given before breakfast, 15 before lunch, and 15 before dinner. So this is how we give the correction bolus for high blood glucose levels, which is like more than the target level. I hope I'm being clear. Next, moving on to the basal bolus regimen. It is basically a combination of both the basal insulin and the bolus insulin. That means the long acting plus the short or the rapid acting insulin as well. So basal bolus routine usually involves taking a longer acting form of insulin to keep the blood glucose level stable through periods of fasting, and separate injections of shorter acting insulin or rapid acting to prevent rise in the blood glucose levels resulting from meals. So long acting to prevent during the fasting time, and the shorter or the rapid acting to prevent the rise in the blood glucose during the meals time. So first step in the process of transitioning from the basal only to a basal and bolus insulin regimen is determining a patient's starting insulin doses. So for calculating the basal bolus regimen, the first thing that we need to do is calculate the total daily dose of the insulin that the patient needs to take. Okay. And now, for example, we have calculated based on the weight of the patient. If we have taken 0.55 and we have got the total dose as 48 units, as we can see here, this is an example. The current total daily dose or total basal dose is 48 units. To give the basal bolus regimen, we have to divide this 48 units into two parts. So basically, the 50% of the 48 units should be the basal insulin, and the other 50% should be the bolus doses that we give in 3 times. So first 50% should be the direct basal insulin that is we give in the night time, that is the long acting insulin, and the next 50% should be divided into three to give it 3 times before the meal. So here we have taken an example of the current 48 units. If the requirement of the patient is 48 units, then we divide it into two. First we divide it into two. That becomes 24 and 24 units. So 24 units, we give it as the basal insulin dose, that is either Tresiba or Glargine or Degludec in the night time. And then the other 24 units of the bolus, that is the short acting or the rapid acting, should be divided into three, which becomes 8 units 3 times in a day. So 8 units of the rapid acting insulin to be given 3 times before the meal, and 24 units of the long acting insulin to be given at the night time, which is the basal, to cover the night time. So 8 units to cover the blood rise in the blood glucose levels, which results from the meals or the carbohydrate intake, and 24 units to cover the periods of fasting. Now next, some of the, I hope I have been clear with the calculations. So moving on to the adverse effects. A few of the adverse effects of insulin are the first and the most common is low blood glucose. Insulin is usually intended to lower the blood glucose, but sometimes its effects can be more powerful than your need. Low blood glucose is the most common insulin side effect, and this is usually when the blood glucose drops below 70 mg per deciliter. Next, injection site reactions. Injecting the insulin can lead to pain or discomfort at the site of injection, but this is very rare. It can swell, itch, or it can turn red. This is called as injection site reaction. And most of these reactions are very minor reactions, minor irritations which are caused by the injection, and they should not be considered as as allergic reactions. Next, weight gain. Insulin can also cause weight gain. When the insulin helps the cells to soak up extra glucose from the blood, that glucose is converted into the fat. As we have seen that insulin takes up the glucose into the cells. So when it allows the cells to take up extra glucose, that glucose is converted into fat. This ultimately helps the body use its sugar supply better, but it can also lead to weight gain in the patients. Next, headache. It is always possible to develop headaches after starting or changing the insulin dose. While low or high blood glucose levels can cause headaches, a big change in the blood glucose can also be the culprit that can also cause headache, but this is also rarely seen. Lipodystrophy. It is when there is a problem with the fat distribution in the body. There are two types of lipodystrophy that the insulin can cause: lipoatrophy and lipohypertrophy. Lipoatrophy is loss of fat or pits in the skin, whereas lipohypertrophy is enlargement of the fat or thickened skin. When this happens, it usually shows at the spot where insulin was injected. So this is basically seen when we inject the insulin. The changes in the skin is seen. Last is a swelling in the arms and legs. But, well, it is rarely seen, but still insulin can cause the body to retain the sodium and the fluid, which is also known as edema. So holding on to the excessive fluid can affect the arms and legs. This is a very rare side effect, and it usually goes on its own, goes away on its own. So these are some of the adverse effects or side effects of insulin. Next, let's see a brief about how to treat the hypoglycemia. First, what is hypoglycemia? It is when the levels of the sugars drops below the normal range, that is healthy. So for most people with diabetes, the hypoglycemia is when your blood sugar level is below 70 mg per deciliter. Uh, the signs include shaking or trembling, weakness, sweating and chills, extreme hunger, faster heart rate, dizziness or lightheadedness, confusion or trouble concentrating. The American Diabetes Association, that is the ADA, recommends the 15-15 rule to treat an episode of mild to moderate hypoglycemia. When you experience hypoglycemia, that is these kind of signs, if we experience, then we can eat or drink 15 grams of fast acting carbs to raise the blood sugar. Then after 15 minutes, we should be checking the blood sugar. If the result is higher than 70 mg, then it's good. We should instruct the patient to eat something with the protein and carbs to maintain the glucose level if the next meal is planned more than 1 hour late. But if the blood sugars are still below 70 mg per dl, then we have to have another 15 grams of fast acting carbs and repeat until the blood sugar is at least 70 mg per dl. And in cases of very severe hypoglycemia, that is the blood sugar becomes less than 54, then emergency glucagon treatment or intravenous glucose is advised. A bolus dose of glucose, intravenous glucose is given, which usually tends to increase the blood glucose levels. Hyperglycemia, that is a condition where the levels of glucose in the blood is higher than the normal. So person with diabetes, usually hyperglycemia is considered to be blood glucose level greater than 180 mg per dl 1 or 2 hours after the eating, that is postprandial. But again, this can vary depending on the target blood sugar goals. The symptoms include urinating larger amounts than usual, increased hunger and or thirst, feeling tired, weight loss. The treatment depends on the cause of hyperglycemia, and it includes insulin, as we have just discussed. For people with type 1 diabetes, insulin is the main treatment, whereas it can also be a treatment for type 2 diabetes, along with some glucose lowering medications. So various drugs such as metformin can be used to lower the blood glucose levels. Next is the blood glucose monitoring. People with diabetes should always monitor their blood glucose levels as they have been instructed by their treating physician. And lifestyle changes, of course, people with diabetes can reduce the risk of developing hyperglycemia or treat existing hyperglycemia by getting regular exercising, following a nutritious diet, and maintaining a healthy weight. Maintaining a healthy lifestyle is always important. So this was about hypo and hyperglycemia. There is also a condition which is called as diabetic ketoacidosis, where, one second, I think there's some problem with the screen. Okay, so there's a condition with high, when there are high levels of glucose in the body, or due to dehydration also, there's a condition called as diabetic ketoacidosis. So we'll just go a brief through diabetic ketoacidosis, as we are already running a little, we're reaching the time. So diabetic ketoacidosis is a life-threatening problem that affects the people with diabetes, mostly people with diabetes. It occurs when the body starts to break down the fat at a rate that is too much fast. The liver processes this fat into a fuel which is called as ketone, which in turn causes the blood to become acidic. And hence this is called as diabetic ketoacidosis, DKA. It happens when the signal from the insulin in the body is so low that the glucose cannot go into the cells to be used as a fuel source. The liver makes a large amount of glucose and the fat is broken down too rapidly for the body to process. So DKA is some 1 second. So DKA is sometimes the first sign of type 1 diabetes in people who have not yet been diagnosed. It can also occur in people who already have been diagnosed with type 1 diabetes. Infection, injury, or a serious illness, missing doses of their insulin shots, or stress of the surgery can lead to DKA in people with type 1 diabetes. People with type 2 diabetes can also develop diabetic ketoacidosis. It is usually triggered by prolonged uncontrolled blood sugar levels, missing doses of their medications, or if there is a serious illness or infection. So the treatment usually involves the fluid replacements because of dehydration. So the fluids replace those lost through too much urination. They also thin out the blood sugar. Fluids can be given by mouth or through a vein, and when it is given through vein, it is called as IV fluids. Electrolyte replacements. Electrolytes are minerals in the blood such as sodium, potassium, and chloride that carry an electric charge. Too little insulin can lower the level of several electrolytes in the blood. So IV electrolytes are usually given to keep to help keep the heart, muscles, and nerve cells working as they should. And insulin therapy. Due to hyperglycemia, insulin reverses the diabetic ketoacidosis. In addition to fluids and electrolytes, insulin is given usually through a vein. A return to regular insulin therapy may be possible when the blood sugar level falls to 200 mg per deciliter and the blood is no longer acidic. So this is a very simple flow chart of the treatment of management or the management of diabetic ketoacidosis, where we give where we start with IV fluids. We start with hydrating the patient by giving 0.9% of sodium chloride at 15 to 20 ml per kg for the first hour, and then depending on the hydration status or the serum sodium also, we give either 0.9 or the half, that is 0.45% of sodium chloride and 4 to 14 ml per kg per hour. And when the blood glucose reaches 250 mg, then we have to change to 5 to 10% dextrose. The reason we are changing is to dextrose is that we can also not let the body turn into hypernatremia, that is high levels of sodium also. So we change to 5 to 10% of dextrose along with 0.45% of sodium chloride at 150 to 250 ml per hour, and continue the IV insulin at 0.05 or 0.1 units per kg per hour. Monitor the clinical condition and check the glucose every 1 to 2 hours and electrolytes every 2 to 4 hours. Insulin, we usually tend to give IV insulin infusion in patients with diabetic ketoacidosis because the sugar levels shoot up very high. And so the 0.15 units per kg of IV bolus of the regular insulin is given first, followed by 0.1 units per kg per hour of IV infusion. If the blood glucose does not decrease by 50 to 70 mg, then we again need to repeat the IV bolus dose, followed by we have to double the infusion rate till the blood glucose decreases by 50 to 70 mg. And then the potassium, as we have discussed, the electrolyte, specifically the potassium. If the serum potassium is more than 5, then we do not need to supplement the patient with any potassium. If the potassium is 3.5 to 5, then we can give 20 to 40 MEQs in 1 liter of IV fluids for the electrolytes to not go lower. If the potassium has gone below 3.5, then we need to give 40 MEQ of potassium per hour, and we need to maintain the serum potassium levels at 4 to 5 MEQ per liter. So yeah, that's it about insulin and the treatment in diabetic ketoacidosis. There are few references. So thank you so much. I hope I have not bored all of you.
Good evening, everyone. Thank you, Dr. Sufia ma'am, for this insightful webinar. And we have certain questions in our chat box. Can we go for them, ma'am?
Yeah, can I just see I'm just having a look at the questions.
Yeah, yes, ma'am.
Yeah. Which one is recommended during hypoglycemia? 5% dextrose, 25% dextrose, or DNS? In the cases of severe hypoglycemia, we either go with 5% or with 25% dextrose. DNS not really, but it depends again based on the sugar. If it has gone like really low, 25 like below, like around 25 to 30, then we give it then we give the highest concentration, that is 25% of dextrose. But if it is like 30 to 50, then we give 5% dextrose as well. Mostly we give a bolus dose of 25% dextrose only, so that the sugar levels go higher quickly as soon as possible. Dextrose normal saline not really in cases of hypoglycemia. I hope that has cleared that doubt. Does the Basal-Bolus regimen calculation uses correction factor if blood glucose is high? Yes, it does. We definitely need to use a correction factor. We don't usually supplement the patient with a lot of insulin in the initial times, because we always fear of hypoglycemia or severe hypoglycemia also, which is also not good for the body. So first we give with the starting dose, like we will calculate based on, first we'll start with the weight based calculation. We'll give based on the weight, but again there are certain other parameters internally that differs from each individual, so that weight based dosing might not be enough to the patient, and we need to give a correction factor. Usually when a patient is admitted to the hospital, we do this thing. We calculate the insulin, we set the dosing, and then we start giving. We keep a check on the blood glucose levels. If it is controlled, well and good, but if it is not controlled, then we definitely need to add the correction factor based on the correction factor calculation. And at the time of the discharge, we calculate how much is the insulin requirement of that patient per day. Now that usually it does not happen based on the weight only, because we have added correction factor also. So we see how much is the total units that are required for the patient per day, and then we divide that. 50% will be given in the basal dose, that is the long acting, and the other 50% will be divided into 3, that will be given 3 times before the meals. I hope I have cleared that question. How to calculate the total daily basal dose? Is the same way as bolus dose? Yes, it is the same way. 0.3 to 1.5 units per kg only we calculate. That is the calculation for any insulin actually. I think I'm missing out on a few questions. For type 2 diabetes, do we need to calculate per day requirement of insulin, or just bolus will be okay? I think I did not understand that question properly. Do we need to calculate per day requirement of insulin? Yeah, as I've just mentioned, we definitely need to calculate the per day requirement of insulin, the total requirement, and then whether to give only bolus or bolus and basal, that will be decided by the physician. Actually, the basal and bolus regimen has been started very recently, probably after COVID times. Previously, only mostly bolus doses only used to be given, that is pre-meal used to be given. But yes, we need to calculate the total amount of insulin required, and based on that we'll be dividing. Giving potassium chloride infusion in hypokalemia associated with decay. Do we use 0.9% normal saline? And how volume is corrected? Volume, Yes, we dilute potassium chloride in 0.9% only. And how the volume is recommended, how much volume is recommended. Okay, there are standard guidelines for the dilute. As far as I can understand, it is regarding the dilution of potassium chloride that you're asking here. So there are standard guidelines always for dilution, especially for concentrated electrolyte. We must be knowing that potassium chloride is a very concentrated electrolyte, and there are different standard dilutions of potassium chloride. Again, it differs from through which IV route are we giving. Are we giving it through peripheral route, or are we giving it through central line? So the dilution differs in both of them. So yes, but we dilute it at 0.9% only. Okay, how to use insulin pen in a correct manner, correct dosage. Correct dosage, as I've said, that we need to calculate it again, the per day requirement, and based on that, the units will be set in the insulin pen. How to use the insulin pen in a correct manner? Okay, so this is one good question, because this is one thing where we have experienced that patients take it in a wrong manner also, or in a slightly different manner. This is where this is one place where the clinical pharmacists play a very important role. When we explain the discharge or the medications to the patients at the time of discharge, we also explain them how to give how to get their insulins administered as well. So there is a pattern in which we explain. First, we explain where is the insulin stored properly, and then we explain what are the sites of insulin administration. That means, as I've said, it is either in the hands, thighs, or in the abdomen. But because the hands and the thighs have less fat tissue than the abdomen, so we always recommend the patients to take insulin on their abdomen only when they're taking it, when they're self-administering it at their home. So it should always be taken at a straight nine. The pen should be kept at a straight 90-degree angle. And then, yes, where is the starting button, how to press the button, everything we will explain in that way. In the how to use insulin pen in a correct manner is, I think your question is regarding this only. How can it be administered, as far as I have understood? So yes, it should be administered. The more preferable way is to administer it on the abdomen, uh, where the most of the fat tissue is there, and it should be at a straight 90-degree angle. And we should never rub the injection site after taking the insulin, as it can cause bruising.
Thank you, ma'am. As we come to the conclusion of this insightful webinar, it is my privilege to extend a heartfelt thanks to everyone who made this event a success. First and foremost, I express my deepest gratitude to our distinguished speaker, Dr. Sufia Iram Irshad, for her time, effort, and invaluable knowledge. The thought-provoking insights on mastering insulin therapy, types, dosing, and management in diabetes care has enriched us and left us with much to reflect on. A big thank you to the Medodrix team for their unwavering support and meticulous planning that made this event seamless. To our participants, thank you for your enthusiastic engagement. Your curiosity and involvement have added great value to the session. Finally, I would like to acknowledge the technical team whose efforts ensured that this webinar ran smoothly without any glitches. A special thanks to Ms. Asfa for her work. Your support is indispensable. Let us carry forward the knowledge and insights gained today. Once again, thank you all for joining us, and we look forward to seeing you at our next webinar. Have a great day.